This video is to talk you through a new component that we've added to the workflow M pages called Care Pathways. We've deployed this initially to try and support management of patients with suspected or confirmed COVID-19. So this Care Pathway component has been put into the Admissions and the Manage tab of the workflow M page. So this should become part of the routine clerking and potentially of the ongoing walk-down noting for these patients. So if we click on Care Pathways, you'll see there's an available pathway up here. There's only one available as COVID-19. And if I click on Start, that will now open a new tab up here, which will commence my guided treatment algorithm. So this is essentially an algorithm that it will work through, ask me a series of questions, and then my advice and recommendations will be given over here. There are three phases to the algorithm. The first is initial assessment, which is aimed at the initial ED assessment to decide whether the patient needs to be admitted at all, whether they can go onto the ambulatory virtual follow-up pathway, or whether they need to be admitted directly. The second phase is for escalation assessment for all patients who are admitted. And the third phase prescribes or offers you the prescription options for relevant antibiotics according to the somewhat complex community-acquired pneumonia COVID-19 pathway. So that simplifies that. That means you don't have to go looking it up in the micro guide, and it will give you the relevant recommendations and just a click button to prescribe those antibiotics. So if we start off on the initial assessment, this patient who I'm seeing has come in. They have a sore throat, they're breathless, they have a persistent cough, they've had close contact with somebody with COVID-19, they have a fever, and if they have acute respiratory distress, then the system will directly recommend admission for that patient. If they don't have acute respiratory distress and don't have chronic hypoxia or COPD, if their saturations are satisfactory and the saturations don't drop on exercise, and they have a normal chest x-ray, and I don't have any particular concern, then the system will recommend I discharge the patient. I advise them to contact 111 if they get to deteriorate, or 999% deterioration, and it gives me the option to order a COVID-19 swab if I so wish. But that will now go up here to my Amazon inbox. All the details are completed for me, so all I have to do is press sign, and that order has now been placed. If, however, I have a patient with a sore throat, nasal discharge, a temperature, who has no acute respiratory distress, does have COPD, saturations are satisfactory, and they don't drop, and there is evidence of radiological consolidation. The recommendation is that I'm going to discharge this patient to the ambulatory pathway. So I've ordered the SARS already. I'm going to click on the order for referral to ambulatory and sign that. You can see that the patient has been placed on the referral list for the ambulatory referral process. I'm going to take you through a different patient who's got a sore throat, breathlessness, cough, fever, acute respiratory distress, and this patient also has radiological consolidation. The recommendation is that the patient gets admitted. I'm reminded to check that the next of kin contact details have been documented so that I can call them if I need to, if the patient deteriorates. I've done that. I'm reminded to take a blood gas, and I've already ordered the care set on the previous incarnation of this patient, but I'm advised now I'm going to save this, and I'm going to go to the escalation assessment. So this is crucial as it helps us to decide up front whether a patient is likely to get full escalation of treatment or whether they should have limited treatment escalation. So first thing is to remind me to document the resus process as per the standard DNA CPR process within EPR and have that discussion with the patient. This patient has a frailty score of 1, they're fully well and unlimited, they have no dementia, and they have none of the Apache 2. These are the key ITU criteria, in addition to frailty and dementia, which would make it less likely that you would get full intensive care therapy. So this patient has none of the above. So I'm advised this patient would be for full escalation. I'm recommended where the patient should be ideally transferred to. The patient should have at least hourly saturation monitoring or preferably continuous saturation monitoring. I should have early escalation to intensive care if the patient starts to desaturate on high flow oxygen, or contacting outreach if the patient requires more than 40% FiO2. We are advised to avoid excess fluid, consider furosemide if appropriate. All these patients should be offered paracetamol and oxygen and appropriate VTE prophylaxis. And again, I can order all 4 of those things just by pressing this one button if I so wish. The oxygen prescription requires me to fill in the oxygen assessment form. The patient is not on oxygen therapy. There's no risk of CO2 retention. Ideally, we're going to use a Venturi because it minimizes oxygen demand on the system and continuous oxygen. I'm going to save that. And then it's going to take me to antibiotic treatment. And this patient doesn't have a penicillin allergy. They're confused, have a respiratory rate above 30. If their age was above 65, that would auto-complete for me. And they have a oral route is possible and appropriate. So this tells me that the curb 65 is 2, and recommends amoxicillin, doxycycline. So again, I'm going to press order all. All 3 of those drugs have now appeared in my inbox. I'm going to sign. If I go to the drug chart now, you'll see I've prescribed amoxicillin, doxycycline stat of 200, appropriate dosing there, furosemide single dose, regular paracetamol, prophylaxis, and oxygen. If I just go back to the treatment escalation assessment, just to show you if the patient had a Apache of dialysis, then you'll see that they're unlikely to benefit from intensive care and they're generally be for ward-based care. Should prescribe oxygen as previously. The same rules about fluid balance. This just reminds me that I need to discuss the escalation strategy with the patient and with the next of kin. I can confirm whether I was able to do that, whether I couldn't get hold of the next of kin. And I can save that. And then finally, if the frailty score was very high, or the patient has moderate or severe dementia, or significant number of Apache scores, then again I will be advised that intensive care is highly unlikely to be beneficial and wouldn't normally be considered, and that we should be offering oxygen to a target saturation of 90% or above for non-COPD patients, or 88 to 92 for chronic hypoxic patients. The same rules about paracetamol, antibiotics, and furosemide if required. And again, I want to discuss it with the patient and ideally with the relatives if possible, and save. So that gives me all the assessment parameters and treatment parameters and orders in one place. I still need to complete my clerking as regards other issues, such as the problem list, patient's past medical history that they may have, whether they have diabetes, anything else they have, any other comments in free text that I need to do, and I still need to enter the home medication. However, if I now, rather than using the conventional admission clerking note, I use the COVID-19 clerking note, this will automatically bring in for me all the information that I entered in that COVID-19 pathway. So you can see the escalation information, the antibiotic treatment I've recommended, and from a clerking perspective, all the symptoms that I entered in terms of the patient's presentation. This patient was admitted with acute respiratory distress and consolidation on the chest x-ray. So please make sure you still complete additional relevant information in the history, the patient's past medical history and drug history. I can now sign that in the usual way. And for future ward round notes, if I use the Manage tab, you'll see the care pathway component is still available. And similarly, if I can create a COVID-19 ward round note with the same information in it if I want to, or a consultant ward round note, or if I simply want to enter the COVID-19 pathway information in a place of my choice, I can type #CovidCP, and that will bring in all the up-to-date information related to the pathway. And when the patient's finished the pathway, I can complete it, and that will sit in the patient's historical pathways long term. We will be bringing in other new care pathways in the future, which I hope will help guide management and treatment and standardization of care of these patients. But for now, I hope this is useful for treatment of patients with COVID.